guys, and welcome back to my YouTube channel. And today we're going to discuss a very important and a very interesting topic, which is electrocardiogram. Electrocardiogram, ECG or EKG, it is called as both. And electrocardiograph is the device which we use to record this. So let's begin with the conduction system of the heart, and then we'll proceed forward to how is the ECG paper and how we study it, right? So this is the SA node in the heart, right? In the right atrium, the node which is present is the SA node, which is also called as the natural pacemaker of the heart. And then the secondary one is the AV node or atrioventricular node. This is a sinoatrial node, and this is the atrioventricular node, right? So these two cells in the heart are excitable. They are self-excitable. They can produce their own impulses, due to which they conduct the electrical impulses. So what happens is the SA node generates the electrical impulses, then it travels to the AV node. Then AV node forwards this and it goes through the bundle of his, then to the Purkinje fibers, which leads to the contraction, which leads to the ventricular contraction, right? So this is how basically the conduction system of the heart works. From SA it goes to AV, then via bundle of his, then via Purkinje fibers. So this is how the heart is basically contracting. Now let's see about the ECG paper. So there are 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. So it is a 5 by 5 square, right? And each square is 1 mm. And every 1 mm, one small box represents 0.04 seconds. So this one of the small box is 1 mm and it represents 0.04 seconds. So 5 of them represents, which is 0.20 seconds. So there are 5 small boxes which form one large box, right? This is how the ECG paper is made. 5 small box make one large box, right, at every place. So this is how it is made. And this is the amplitude over here. The whole length is, like, if one box is 1 mm, then the whole thing is 5 mm, right? So this provides an amplitude of 0.5 millivolts, 0.5 millivolts, right? This is how the graph is. This is how the ECG paper is read. So each small box over here represents time. So if we see on the x-axis, we see time. So time is 0.20 seconds for every big box. This is a big box. 1, 2, 3, 4, 5 of them together. 5 into 0.04 is 0.20. So this makes one big box. And amplitude again over here, each is 1 mm, right? So each is 0.1 into 5. So 0.5 millivolts is the amplitude we get here, which is on the y-axis. So this is how the paper is there. There are multiple boxes. For every fifth box, it is highlighted. Every one big box is highlighted, right? So you can see, if you see it on the actual paper, this part will be more highlighted. So now the speed of the paper is, the normal speed is 25 mm per second, right? 25 millimeter per second. But in case of tachycardia, if the patient is having tachycardia, then the speed of the paper can be adjusted to 50 mm per second, right? 50 millimeter per second. Now let's study about the bipolar limb leads, how these leads work. So two limbs are connected to obtain these leads. So two limbs are connected to obtain such a way that both leads are in opposite polarity. Both leads are in opposite polarity. If this is positive, this will be negative. This is negative, this will be positive. Right? This is how it is connected. So this is the right arm, this is the left arm, and this is the left leg, right? Left leg, and I have written F over here, which represents foot. I will tell you why I have written V1, V2, and V3 over here. So this represents L1. L1 is lead 1. Then there is L2, which is lead 2, which moves from right arm to left leg. Then there is lead 3, which moves from left arm to left leg. And there is lead 1 from right arm to left arm, right? This is how it moves, negative, positive, and positive in polarity. So to calculate the voltage, right? To calculate the voltage at points V1, V2, and V3, we have a formula, or we have a schematic representation. It is called Enthoven's triangle. Enthoven's triangle. So this can give us the voltage at any given point. So what is the formula for V1? So it is the summation of the current which is moving from left side, right? The left side, the left arm minus the right arm, right? Left arm minus the right arm. Now don't confuse with the polarity that negative times negative becomes positive. No, there is no such things like that. So this is simple arithmetic, normal math. This is for V2. V2 is over here. So what is it? Foot, left leg of foot, foot minus right arm, foot minus right arm. And V3 is what? Again, foot minus left arm, foot minus left arm, right? So this is how I have shown you the arrow, how it moves. So what is L1? So we have 6 leads present over here actually. I will tell you how this lead works, where we place these leads. So let's see. Lead 1 is placed in the right arm, right? It's connected to negative and left arm is connected to the positive. So this is lead 1. This is the position of L1, right? L1 is connected over here. So as I told you, this is always in opposite polarity. So as I told you, L1, right arm connected to the negative. Right arm is connected to negative and left arm is connected to positive. L2 again, right arm is negative and left leg is positive, or you can call the foot is positive, right? Next, coming to L3, lead number 3, which is left arm is negative over here and left leg or the foot is positive. So this is the positioning of L1, L2 and L3. On anatomically how it is placed, I will show it to you in a while with a schematic representation where is it exactly placed anatomically. Next we go to the unipolar leads, right? This was a bipolar lead system. Let's go to the unipolar lead. So there are two types. One is the limb lead and the other is the chest lead. So a lead composed of single positive or active and reference point, which is composite and which is negative, right? So one of the site is positive and the other, right, which is a reference point, which is composite negative, right, which is a negative electrode placed. So what happens over here is we have first is initially augmented limb or vector lead. So what happens over here? This is an active lead, positive, connected to one limb in different electrode, that is negative. So a positive lead is connected to the other limb, which is negative, to other two limbs, right? So we connect two limbs which is negative. One of them is the reference, which is the negative, and one of them is a positive and the active lead. So we have L4, L5 and L6. L1, L2, L3 we studied over here. Next is L4, L5, L6. So what happens in L4 is augmented vector right? So this is augmented limb or vector lead. So this is augmented vector right, AVR. Right arm is positive, negative is connected to the other two limbs. That is left arm and left leg, right? This is L4. Next is L5, right? This is augmented vector left. So what happens over here is left arm is positive and right arm and left leg is negative. So always there is one positive and two negative. Two limbs are always negative and one limb is always positive. Next is L6. Lead number 6. This is augmented vector foot. As I told you already. Augmented vector foot. So what happens over here is the left leg is positive. So here is how we get to see how the ECG is formed on paper. So this is for augmented vector foot, augmented vector left, vector right, augmented vector right. So this is how it is represented. So L4, L5 and L6. So this is the representation. Now coming to this is a classic representation of an ECG, how an ECG actually looks. So initially it starts with the P wave, then Q, R, S and T. Here it subsides, right? So in this we have certain intervals such as the PR interval, QT interval, the QRS complex and the ST segment. So each of them have their own clinical importance. We will study them in detail, and for now we will see the positioning of these 6 leads, where are they placed specifically. What is the anatomical position? Definitely they are placed on the chest, but where exactly on the chest? So guys, let's continue about the unipolar chest leads. It's also called as the precordial leads. So there are 6 leads basically, right? There are 6 leads over here. So these are 6 leads, each consisting of positive electrode placed on 6 points, right? They're placed on 6 different points of the patient's chest, and indifferent electrode, which is also called as a negative electrode, which is also for the reference. It is connected to 3 limbs, that is right arm, left arm and left leg or the foot. Through it has a resistance of 5000 ohms, right? It has a resistance of 5000 ohms. So what does resistance? If we see in simple formula, we used to study in 12th, V is equal to I R. So R will be V upon I. That is nothing but voltage upon current, right? Voltage upon current, that is resistance. So it is connected to a resistance of 5000 ohms. Resistance is represented in ohms. So let's see the positioning of these leads. So V1, right? V1 it is present in the 4th intercostal space, right? 4th intercostal space between the 2 ribs, from right sternal border. Right sternal border, that is the right border, the border of the sternum from the right side, right? Right sternal border. Next is V2. V2 is connected to the 4th intercostal space from the left sternal border. V1 is from the right sternal border, V2 is from the left sternal border. V3 is connected between V2 and V4. So V4 is located between the fifth intercostal space from mid-clavicular line. So you all might know what is mid-clavicular line. If this is the clavicle, the line passing between the clavicle is the mid-clavicular line, right? That is the mid-clavicular line. On the left side, now V5, right? It is also present in the fifth intercostal space from the left anterior axillary border. So what is this anterior axillary border? If this is the arm of the patient and this is the rib, suppose, a line straight over here, this is the arm, so this is the axillary line, left anterior axillary line. And similar way V6, which is present at the fifth intercostal space from on the left side itself, yes, but mid axillary line. Over here is the anterior axillary line. The mid axillary line will be present somewhere over here. This is anterior, this is mid, right? So this is the positioning of V1, V2, V3, V4 and V5 and V6. So this is asked what is the positioning of these leads, and these are also important to know. And next we will study about ECG on a whole, like the P wave, Q wave, R wave, and the entire segments also, right, in detail. So guys, let's study how a normal ECG works and what each wave represents. So a normal ECG has 5 waves, that is P, Q, R, S and T. And there are various segments which is also divided. So this is the P wave, Q, R, S. This is generated as one complex which is also called as the QRS complex, and then there is the T wave. So depolarization and repolarization. That's how it begins. So the P wave arises when impulse from the SA node sweeps over the atria, right? This shows atrial depolarization. So the depolarization is taking place over here. The duration is 0.1 second and amplitude is 0.1 to 0.12 millivolts, right? This is the P wave. This shows basically atrial depolarization is taking place at this point. Next is the QRS complex. So Q, R and S, QRS complex. So rapid spread of impulse from AV to AV bundles, right? That is bundle of His and Purkinje fibers, right? So this is what is happening over here. There is ventricular depolarization. So the duration of this is 0.08 to 0.10 seconds, and amplitude of this is, for individual waves, for Q wave it is 0.1 to 0.2 millivolts. For R it is 1 millivolt, and for S it is 0.4 millivolts. So this is the QRS complex which represents ventricular depolarization. Next, coming to the T wave, this marks the end, right? This marks the end of the ECG. So what is happening over here is ventricular repolarization. The duration is 0.2 seconds and the amplitude is 0.3 millivolts, right? 0.3 millivolts. So now the ventricular depolarization was there, so T is marking the ventricular repolarization. But you might have a doubt that if there is atrial depolarization, where is the repolarization? So what happens over here is atrial repolarization occurs during ventricular contraction. So when the ventricular depolarization, or when the ventricles are contracting, right, atrial repolarization occurs at that point and is not seen in ECG. It is not seen in normal ECG because the QRS segment is very large. The QRS segment is very large, so we are not able to see the atrial repolarization. So the ECG originates from the SA node, right? As we all know, the conduction system of the heart, it originates from the SA node, and hence we call this a normal sinus rhythm. So if the ECG is originating from SA node going to the AV node, then through the bundle of His and Purkinje fibers, this is called as a normal sinus rhythm. Normal sinus rhythm. So it is this is a normal sinus rhythm, and the rate of this rhythm is 60 to 100 beats per minute. 60 to 100 beats per minute. This is a normal sinus. So now talking about interval. So what is a PR interval? PR interval is basically PQR, right? PQR, between onset of P wave and Q wave. So this flat line, if you see this PQR, so this point specifically would be the PR interval. So what happens over here is the impulse is going from the SA node to the ventricles. So the from the SA node, which is present in the atria, it goes to the ventricles via the auriculoventricular node or the atrioventricular node, and the duration of this is 0.12 to 0.20 seconds. Next is the RR interval. This is the consecutive time between two R waves, right? Time between two consecutive R waves, and the duration of this is 0.8 seconds. So RR interval is very important for the ECG point of view. We can calculate the beats per minute using RR interval also. I will tell it to you in the next part of the lecture how we can analyze an ECG and do certain calculations. Next is the QT interval, Q and T. Time between onset of Q and end of T. Onset of Q and end of T, right? QT interval. So what is happening over here is a ventricular depolarization and repolarization. So depolarization started here and it is terminated by the repolarization of the ventricle. This is what the QT interval represents. Next is the duration of this is 0.20 to 0.40 seconds. Next is the PR segment. So PR segment is a flat line between P and starting of the QRS complex. So P, this line very specifically, the line I have circled, right, that flat line, that is the PR segment, right? The PR segment. And the time, and what does it indicate? It indicates the time delay between the atria and the ventricular activation. So how long it is taking for the transformation from atria to the ventricle. So what is happening is atrial depolarization, repolarization, the ventricular depolarization has to take place. So this duration gives us the time, how much time it is taking for the transformation from the atria to the ventricle, right? This is the PR segment. Next is the ST segment, right? ST segment. So it is the time between end of S wave and onset of the T wave. End of S wave and onset of the T wave. So what it shows is time between depolarization and repolarization of the ventricle. So the time between depolarization, so here the depolarization ends and repolarization begins, right? That's what the ST segment indicates. Depolarization and repolarization of the ventricles, and time duration is 0.08 seconds. So this is how a normal ECG functions. Now we will see what happens if there is a pathology of these waves, right? If there is a pathology of these waves, and by this if I mean is that if the waves are elevated or depressed, what are the conditions which can cause this? I will tell it to you in detail, and in the next part of this lecture we will discuss certain calculations, how we can calculate certain things from the ECG, right? So guys, let's begin with the pathology of the various waves and their clinical significance. So in case of P wave, which represents atrial depolarization, the duration is 0.1 second. So this is a normal P wave. This is right. This is a right atrial fibrillation. In case of so this is right atrial hypertrophy and left atrial hypertrophy. So these are the two significant signs we can see over here. So in case of this, the P wave is elevated, and in case of left atrial hypertrophy, what happens over here? It takes a more M shape, right? It takes a more M shape. So so what happens over here is right atrial hypertrophy. The wave is more tall. It is taller than 2.5 millimeters, right? 2.5 millimeters. And in case of left atrial hypertrophy, what happens is the wave is tall and broad at the same time, so it resembles a shape M. It resembles a shape M. So we can see various cases. In case of hyperkalemia, that is elevated blood potassium level. Hyperkalemia is elevated blood potassium level. So what happens over here is the P wave is either absent or it is small, right? The P wave is either absent or small. In case of atrial fibrillation, what happens is the T wave is completely absent. The T wave is completely absent. In case of SA block, it is absent or inverted. It is absent or inverted. So you can see the P wave like this. It is absent or inverted, right? Small P wave is seen in increased normal rhythm or increased nodal ectopic and atrial tachycardia and ectopics, right? These are the conditions where you can see small P wave. The P wave is small. You can see it inverted in case of nodal rhythm with retrograde conduction and dextrocardia. The heart is located on the other side in case of dextrocardia. Next is variable P wave is seen in case of wandering pacemaker. Wandering pacemaker, it's a disease. You can see variable P waves in such condition, and you can see multiple P waves in tertiary heart block, atrial flutter, which is sawtooth. So you get a sawtooth like P wave seen on the ECG. Next is the QRS complex. So what happens over here is ventricular depolarization and repolarization takes place over here. So there are two conditions over here. In case of hyperkalemia, it will be prolonged. QRS complex is prolonged, whereas over here it was absent or small, right? Next is bundle branch block. In case of bundle branch block, what happens is prolonged or deformed QRS complex. Either the complex is prolonged or it is deformed. Next is the PR interval, so impulse from transmission from SA to AV, right? Duration is 0.12 to 20 seconds. So what happens is it is prolonged in case of bradycardia and primary heart block. We have three types of heart blocks: primary, secondary, and tertiary. We will discuss in detail in future. So in case of primary heart block, what happens is this is prolonged, and in case of bradycardia, that is slow heart rate. In case of tachycardia, it is short. The PR interval is short. That is why you get to see more waves on the ECG, right, as the heart rate increases. Next is the ST segment. So this is an elevated ST segment. A normal ST segment is just flat and then it goes. Here it is elevated, right? So there is a point over here specifically. It is called as the J point. It is between QRS complex and the ST segment, right? It is between the QRS complex and the ST segment. So duration is 0.08 seconds. Elevation in case of acute myocardial infarction, acute pericarditis, that is inflammation of the pericardium, and Prinzmetal's angina. So this is what is this? What is this Prinzmetal's angina? This is non-infarction. So there is no infarction over here, and it is a transmural ischemia. So there is just pain. It is not an infarction. It is a pain, right? Next is ventricular aneurysm. Ventricular aneurysm, when the blood supply is cut off due to aneurysm. So in case of that, you can see an elevated ST segment. Depressed in case of acute myocardial infarction. Both are same. Both conditions can apply over here if it is elevated or depressed. Angina pectoralis, that is pain at the time of myocardial infarction or before the onset. Next is ventricular hypertrophy with strain. Ventricular hypertrophy, that is increase in size of the ventricles with strain when put under condition of stress. This happens generally in case of hypoxia, that is low oxygen. Next is acute true posterior myocardial infarction. So this can be seen in leads V1 and V2, right? Next is in case of reverse tick sign. What is reverse tick sign? This is basically when we use the drug digitoxin. So the toxicity due to which this drug, it shows a sign called as the reverse tick sign, and over here we get to see an elevated ST segment. Very important reverse tick sign, digitoxin toxicity, and ST segment is depressed over here. The ST segment is depressed, right? Over here it is elevated, the same thing will go down over here. So reverse tick sign, please remember, very important clinically. So coming to the QT segment, so what happens over here is there is ventricular de and repolarization, right? And the timing is 0.4 to 0.42 seconds over here. So there are two cases over here. One of them is short and the other one is in long. So what happens is, in case when it is short, there is either tachycardia, hyperthermia, that is increased body temperature, hypercalcemia, that is increased level of calcium in the blood, right? Digoxin effect and vagal stimuli. So when we take the drug digoxin, so we can see a short QT segment. In case of long, so it is just the opposite, that is bradycardia, hypocalcemia, acute myocardial infarction, acute myocarditis, cerebrovascular accidents, that is a stroke, and hypothermia, that is decreased core body temperature. So in these cases we can see a short or a long QT segment. Coming to the U wave, so guys, U wave is a pathological wave, right? It is not physiological, but it is a pathological wave. So between this is a QRS and this is T. So between this, the wave which is coming between S and T, it looks like a U, so it is simply called as a U wave. So it shows the repolarization of the papillary muscles. So it is showing the repolarization of the papillary muscles, and it is seen in case of hypokalemia, that is decreased potassium, ventricular hypertrophy, increase in size of the ventricle, hypercalcemia, increased blood calcium level, and hyperthyroidism, when there is more secretion of thyroid hormone. So this is U wave. Next is the T wave, which is asked for 0.2 seconds and shows the repolarization of the ventricle. So it is tall in case of hyperkalemia, acute myocardial infarction, acute true posterior myocardial infarction, which is seen in V1 and V2, the leads. It is small in case of hypokalemia, hypothyroidism, pericardial effusion. Pericardial effusion, when the fluid from the pericardia is moving outside, that is called as pericardial effusion. And it is inverted in case of myocardial infarction, myocardial ischemia, subendocardial myocardial infarction, and ventricular hypertrophy. In these cases, this is inverted, right? This is the T wave is inverted. Next is the R wave. So it is tall in case of posterior myocardial infarction and RBBB and dextrocardia. So what is RBBB? That is right bundle branch block. So when the His-Purkinje network, right? So as we know from SA, it goes to AV, then to the His and bundle of a bundle of his and Purkinje fiber. That is how the electrical conduction is taking place. So when there is a disruption in the his Purkinje system and it is altered, what will happen is you can see a wide QRS complex, because the depolarization of the ventricle is taking a longer time because the conduction is not able to pass through the his Purkinje system. So what happens here is you can see a RSR complex, that is we see two R waves, they are short, and one large S wave, right? In V1 and V2, in the leads V1 and V2 we can see RSR complex, and in S wave we see a S wave in V5 and V6, and which is broad. So this happens in RBBB. Again, once again, what is RBB? Right bundle branch block, RBBB, right? It is, and next the R wave is small in case of improper ECG, when the standard ECG standardization is not there. In case of obesity, in case of emphysema, hypothyroidism and hypothermia, these are the cases where the R wave is small. And poor progression of R wave is seen in case of angina, that is pain, angina pectoralis, dextrocardia, that is the location of the heart on the right side, and also in case of LBBB, that is left bundle branch block. So what happens over here is there is delay in the his Purkinje system and block in the electrical impulse. So what we see here is a deep and broad S wave in V1 and V2, and clumsy R wave in V5 and V6. So with this we have completed the pathology of various cardiac waves. I hope you guys understood and it was helpful. In the next part of the lecture, we will discuss it on the ECG paper, how to take certain calculations. And if you like the video, do give a thumbs up, like, share it, subscribe, and please do watch. Thank you.